We are here with Dr. Thakkar. Today, we are going to be talking about thriving with Parkinson's disease. This is a foundational program which is in partnership with our friends from Amneal. Going to cover a little bit about what to expect, how to advocate for yourself, for the best treatment, lifestyle choices, and just general things that can help improve your quality of life. So, if you're not familiar with PMD Alliance, which I hope you are, we really like to, we're a nonprofit organization. We are based in the US, but we do have friends that come and join us from all over the world, and who may be watching this later on from our video library on demand. So if that is you, welcome as well in the future. But we are an organization that just wants to help armor each of you with information so that you can take that information and bring it back and apply it to your lives. So, just wanted to give you the opportunity to introduce yourself in the chat, just where you're from. Like I said, we have people who come from all over. Our chat is how we do uh, generally ask questions. I will be monitoring the chat, as will my colleague Julie, who's here. If you have any tech issues, Julie will you probably get a little bit of a note from Julie. And if so, Julie, do you want to pop into the chat? So just for those who haven't been able to, who haven't seen it, are able to see where that is. And if everybody wants to just say, yeah, if you're coming in from, well, I think Julie, you're going to be typing you're from Long Island, New York. So Julie's coming from Long Island. I'm from Southern California, right near Dr. Thakkar, who I'm very excited is with us. Dr. Thakkar, just to introduce him, is a movement disorder specialist. He is a neurologist over at Hoag. And is it Hoag Pickup Family Neurosciences Institute? Is that correct?
Yeah, and I have my own
Okay.
private practice that is OC Parkinson's.
OC Parkinson's, perfect. Yep, he is. So Hoag is out in the OC. Dr. Thakkar is also involved with our VA, their Parkinson's disease research, education, and clinical center in LA. And he's done clinical research on the subjects of deep brain stimulation for the treatment of and the effects diet can have on Parkinson's disease, as well as the effects of certain drug therapies on mood and behavior. And he's also a published a neurologist. He's one of our, especially out here in OC, whenever we have an in-person program, a well-loved speaker of ours. He is terrific. So you are in for a treat today. So Dr. Thakkar, if you want to take it away. And like I said, if you have questions, we will have a Q&A at the end. And so, don't worry if we don't get to it right away, but we will be keeping an eye on those.
Great. Thank you, Rebecca, for that nice introduction, and excited to be involved with education with PMD Alliance. And thank you, Amneal, for providing the slide deck where we're going to be talking about thriving with Parkinson's disease, because you can actually thrive extremely well and manage this disease quite well. I know any disease state can have its different stages and difficulties, but it's really about living your best life. And so we'll talk about how to do that through this deck, and we want to learn more about and what to expect, as we all should be our own advocates, and then also be advocates for our family who suffer from it. So the information today is for education purposes. I'll be taking off my white coat inherently as not being your individual healthcare provider, but please discuss anything that you do want with your neurologist or movement disorder specialist, or even your primary care doctor. Any information that you've learned today that can help your Parkinson's will be key. And all of this information is confidential as far as each of you as participants. And if there's any sort of questions, please feel free to ask accordingly. This is going to be recorded, so please don't identify yourself maybe with your own personal information. So today we want to make sure this education provides as much understanding about Parkinson's disease from my perspective. And by no means can I introduce everything about Parkinson's, but we'll try to enhance what is the most ideal, what I think is on the slide deck to be understanding the discussion back and forth between your symptoms to uh, get the attention of the healthcare provider to optimize one's health. And by no means is this all about just medications, right? Like to thrive with one's health involves like exercise, it's about nutrition, it really is about getting good sleep. So to get the maximal therapy from what we take in, it really is wholesome. So let's talk about all of those aspects of medical management. And we will also have that introduction right now about the disease, but questions about the disease later on. So what is Parkinson's disease? It is probably the fastest growing neurological disorder because I think it's been underreported prior. The numbers say by 2037, 1.6 million people will have disease. I think that's probably an underestimate. We may be even close to that number now because I think we misdiagnose what essential tremor is in comparison to what it develops in slowly over time to Parkinson's. So I do see a lot of patients that come into our clinic. I always tell people there's no such thing as normal to have a tremor. It is never normal to have a tremor. And a lot of movement disorder specialists, after they've seen a patient and evaluated a patient, they're like, well, this isn't really essential tremor. This is actually Parkinson's. It probably has been Parkinson's. So I think we underreport that. And that's where maybe, again, seeing someone who has the evolution and understanding and the background for understanding Parkinson's and essential tremor, you can get early adoption of care, medical management, and get in the right steps to thrive with this disease. So we do end up seeing a lot of patients coming in, maybe have had Parkinson's for 5 or 10 years. I had one patient who was 20 years with the disease, and it was pretty obvious that was 20 years based on the history. But again, why is this a disease? Because it is characterized by loss of dopamine producing cells in the brain. These neurons are not creating the proper pathways of dopamine, and by no means is this only a dopamine dysfunction. We are low on serotonin, we are low on norepinephrine, we are low on numerous neurotransmitters throughout the brain and nervous system. So the nervous system touches your fingers all the way down to your toes. It affects even pathways around the heart. So there are patients who suffer from constipation. There's problems with sleep cycles. There's problems with blood pressure associated with Parkinson's and even bladder. And again, all the nerves and different neurotransmitters do also impact the other systems. So again, making sure you have a really good primary care doctor and so on, or internist that also understands your general health is key to Parkinson's management. The primary symptoms we do see are motor symptoms, which include tremor, stiffness, and slowness. But to really manage this disease state, we have to understand the non-motor symptoms, which we'll address, which includes the cognitive aspects, the GI issues, again, the sleep aspects, fatigue. So who gets Parkinson's and why? So, we have a lot of patients that come in and we diagnose them with Parkinson's and they say, well, but it doesn't run in my family, because it doesn't typically run in the family. It is not really a genetic disorder. The data suggests it's less than 12% of the cases are related to familial. And in my practice, it's probably even less than 5%. So there's a lot of people we call idiopathic, unexplained, but the majority of the data suggests it's exposure to pesticides, chemicals. Around California, the higher centers of Parkinson's are around pesticides in farming areas. Again, where well water, again, could it be in, like, say, Michigan, and we've seen it in different industrial plants all around the US. So exposure and toxins to certain things that we never knew were a problem in the past probably are one of the highest reasons why we're seeing as one of the increasing neurological disease states. More men are diagnosed with PD than women, and that ratio of 3 to 2. We start seeing typical symptoms above 60, and I always say mid 60s for a lot of patients. And as we get older, again, it does not mean that because we have a tremor, it's because of aging. It has nothing to do with aging. There could be a thyroid issue. There could be a B12 deficiency. Someone could have had a stroke in the wrong spot in the brain, and that can cause a tremor. But tremor by no means is normal. Always, advocate to get that checked up and make sure you feel adequate in the diagnosis and have it monitored. So 1% of the population are assumed to have, at the age of 60, will have Parkinson's. Again, I think those numbers, we do see it increasing by 65 and 70, become 1 to 2%, and above 75, it's like 2 to 4%. So it is definitely increasing. And as we saw the numbers, that could be by 2037. So as I commented, the exposure to environmental toxins, I've had patients through the VA who have been exposed to Agent Orange. Again, we know about Camp Lejeune. So those type of increased risk factors also affect those that may be getting cancer. So again, make sure you're getting proper workup and seeing a specialist who understands what those exposures leads to risks. And we are seeing also head injuries. Now, there's probably a higher rate of boxers getting Parkinson's, also football players. We do believe that a lot of the head trauma, even early on before puberty, can affect certain cognitive and motor control issues. There's a lot of mental health issues associated with head trauma. So again, if there's anything that's affecting one's Parkinson's, also look into what other may have created it. And if there's associated head trauma, we may be looking for behavioral changes as well. So the mental health aspects of PD should be addressed as well with the doctors, and shouldn't be shy to bring up if you are having any sort of depression or anxiety or sleep disturbances. These are things that are associated with Parkinson's that we can manage, and then that's why people can thrive with this disease if it's under control. But as we know, Parkinson's is a loss of dopamine. It's a neurotransmitter, chemical signals. These chemical signals become electrical signals, right? So it's kind of like the heart. We have electrical signals that let the heart beat. We have a lot of signals in our brain that are chemical that turn into electrical. And so everything works in a fast, quick, automated way. And in certain areas where the dopamine is low and not producing enough, then the pathways get affected. So we may see a degeneration of the pathway. So just by giving more dopamine doesn't fix the whole problem. It helps some of the degrees of symptoms. What we do see with the motor symptoms, tremor being 80% of the time with Parkinson's. So that means 20% of people do not tremor with Parkinson's. And we typically would think, oh, when I started tremoring is when I was diagnosed. No, tremor could have been the 4th symptom or the 8th symptom, and it could have developed even 8 years or 10 years after you started having rigidity of the muscles or slowness in coordination or difficulty with penmanship. Freezing and shuffling typically happens more than 7, 8, 10 years into disease. If you are getting such freezing of gait early on, could it be also other related like injuries to this, what we call small vessel disease, like tiny little strokes in the subcortical areas of the brain. So that's why imaging is so important to get checked. And again, not everyone gets imaging, but it's important to make sure that we're not missing something, that if we're not getting the great responses that we expect from our medicines. Balance issues, posture can get affected. We start seeing kind of a more rounded neck. We start seeing the shoulders curl in, and that's something that's associated and affects our balance. So always want to work with exercise and knowing these symptoms. That are you responsive to medications? Work on stretching and keeping the body, again, as much more extended and out. There's a lot of wonderful exercise with power moves, big and loud. Again, as we work with special trainers and boxing coaches and dancing, again, really want to work on opening up the girdle. We call it the shoulder girdle, and also the pelvic girdle, because we want to get cramped up, and knees and feet we want to become a little bit more pigeon-toed. So we want to really open up the whole system. And then really understand that speech can be affected. We don't see swallowing issues early in the disease state. And so if there are swallowing issues, whether it's with chewing not chewing enough or having too much in our mouth, we do see that sometimes we have a tough time with the actual swallowing. We can also see that there's regurgitation and GERD, and sometimes some narrowing, and that may not be related to only Parkinson's. So to talk with your primary care doctor as well to let them know that you're getting reflux. I have a lot of patients that we see that have hiatal hernias, and there's a higher association of hiatal hernia with Parkinson's. So a lot of patients do end up seeing a GI specialist as well. So bring up all of these symptoms potentially, and it is our duty to hear them. So do not feel nervous about asking about such symptoms, and if it could be related to Parkinson's. Another kind of non-motor symptom is urinary urgency. I hear that a lot. Sometimes people feel like they have to go to the bathroom a lot. We do see that there's a lot of retention of the bladder, releasing urine, and so we can have higher rates of urine tract infections, which makes us fatigued and tired. So always get monitor for that. Mood can be reduced because of low dopamine, and dopamine also helps mood in other areas of the brain. But we also see serotonin being low. Had a patient today who recalls a year before he was diagnosed, he was getting very anxious. And he says, I don't have that anymore. And he was just thinking about it. Something brought up in his mind that, I used to have this anxiety. I don't have it anymore. And then one of his maybe like a week ago or 2 weeks ago, he said, like, I felt this anxiety come on, and it seemed to be maybe one of his off symptoms, one of his symptoms that he hasn't felt in such a long time. And he was like, I don't know if that's what it is. I'm not sure. But again, it's good to bring up these situations because even before I came on this broadcast, I was anxious. So can anxiety be part of anything, right? Like it's a lot of factors, but don't be shy to bring that up. Constipation probably is the most common non-motor symptom that we see early on in disease and throughout the disease course. So very important to tackle that as naturally as possible, keep well hydrated, work on a high fiber diet. And then pain. So pain isn't really sharp shooting, stabbing pain. It's usually this muscle achiness. It's usually in the distribution of the muscles that are affected more. If it's one-sided more, we see kind of a soreness and achiness, maybe cramping. But pain shouldn't be sharp shooting or electrical sensation. Those can be more neuropathic. We do see a reduced sense of smell. And, you want to definitely clarify, was this pre-COVID versus post-COVID? And did the sense of smell come back or not? And some of those symptoms, we do see that it makes it a little confusing, especially with head trauma. Sleep disorders are a common feature that we as movement disorder specialists ask. We asked if people are acting out their dreams, talking in sleep, and majority of the time we're not aware of if we are talking in sleep or acting out our dreams. We can actually flail and accidentally hit our spouse or partner. It's really important to talk to your partner or discuss any sleep disturbances. If you are dealing with fatigue during the day, sleepiness after taking medicines, sleepiness after meals, that's usually a warning that something's not going right in our sleep rhythm. Fatigue, again, can be associated with a lot of sleep disorders. It can be associated with what we call our parasympathetic drive, and sometimes it can be from medicine. So we also want to address what fatigue means. Maybe even documenting when you get tired, when you're fatigued. This is really important. So bring those kind of timings, and if there's certain patterns of your day, bring those to your clinician, because that may guide us as to when you're feeling like, is it a symptom or is it, due to a lack of effect from a medicine? Because our medicines don't necessarily last so long. And again, our mood, yeah, we can see that anxiety, and rarely do we see agitation, but that can sometimes occur when we're feeling uncomfortable. So the disease motor symptoms are usually unilateral, meaning they start on one side. We feel a sense of weakness, but we're not truly weak. And we may fatigue easier. Maybe we're doing weights and we feel like one side's not as coordinating and it feels like we just can't do as much. Maybe curls, maybe we're on a seated bike and one leg gets a little bit more tired. We're not truly weak because we could still maybe stand on that leg. It just feels like we can't coordinate as fast as we need to. And that's what differentiates a true weakness from like a stroke versus, say, Parkinson's, that we feel weak and we can't coordinate versus being actually able to use it. And then tremors, again, it varies. Tremors can be really fast, and then they can be really kind of slow. They can be around the thumb, it can be the whole hand, it could be even a little bit of a lip tremor, it could be a foot tremor. I had a patient who came in weeks ago who said, I have restless leg, and restless leg was actually the way he was describing it was that his leg was tremoring, and that restless leg that he's had for years was actually Parkinson's tremor and not truly a restless leg. So restless leg is more of a feeling. That one gets when they're laying flat and relaxing, and then all of a sudden they have to have an urge to move. And tremor is involuntary shaking, so that can happen in any part of the body. The asymmetry, again, is that maybe it's a limb, maybe again it's some degree of kind of coordination on one side, but it shouldn't be like an asymmetry of the face itself. Like it's not like one side of the face will droop. So when we're looking at the asymmetry, it's more about the limbs. Symptoms do change over time, and that's why it's a progressive disease. Each person is totally different in their experiences. So when you hear from someone else in a support group, or you talk to someone in a waiting room and they're taking certain medicines, it is typically aligned to their individual symptoms. We do see that people take dosing of different medicines based on their severity of symptoms, based on how many years they've had it, based on timing of their day, So again, if someone's taking a medicine 5 times a day versus 3 times a day, it doesn't mean one person has it worse. It's again based on their degree of how medication is absorbed. Maybe they're on a different medication. We do have longer lasting extended release versions of levodopa that exist. We have obviously dopamine agonists and other once daily therapies and other boosters. So each person to their own has different symptoms. So, it's so key to not assume that when you go to a doctor's office, they would know what you're dealing with. Make sure you're being thorough. I know Rebecca and I were talking before we got on that how do we address certain questions to bring in? Write these things down. Don't think about it as far as just on your memory that you'll bring it up at your doctor's visit. Write these things down because it's so easy to forget. Now take an active role in optimizing your treatment is so true. Again, you got to be your own advocate. You got to say that you have a problem. Don't minimize your symptoms. Just because it's a problem doesn't mean it like the doctor has to reflexively think, oh, here's a pill for it. Like there's other ways of managing. That's what, as a movement disorder specialist, we're trained to say, what other natural ways about it? Is this even part of the Parkinson's phenomenon? What else do we need to do? I had this one person who came in with swallowing issues, and he thought it was just part of the Parkinson. It was normal, and when I felt actually around the throat, I felt a lump, and it was actually a throat cancer. And again, if they didn't bring it up, if they were late to assume that there was something going on, we wouldn't be able to even check. And again, there are things that people deal with that has nothing to do with the Parkinson. So again, never feel that you are alone in this disease state. Again, work with your doctors to help stabilize your symptoms with the least amount of medicines potentially, in the way that it's not compromising your day. So I see a lot of people who want to take fewer doses of medicine per day. So you should talk about, are there any ways of extending the life of my therapy? Is this the right therapy in the first place? It's okay to question what you're taking, and how you need to know if you need to question it is we need to talk about how effective the therapy is. So we want to establish what's called good on time. And good on time means when you have periods of the day, hopefully the entire day, that you feel symptomatically free. You don't have tremor, stiffness, and slowness. And I mean, that's when you feel good and you can do your activities of daily living. When you are able to coordinate without having also too much medicine that makes you kind of disconnected. Now, most people have seen Michael J. Fox, and when he's sitting in an interview, maybe he has tremors, and that could be from nerves. But then when he's really disconnected and wiggling, those involuntary twisting and spasms of the face, arms and legs and trunk, those are from maybe a sense of too much medicine. And so that can also interfere with normal activity. So we want to get the right amount of medicine, not overshoot, and we want to keep it pretty stable throughout the day. But again, not feel like we're taking pills all the time. So talk with your doctor about your symptoms, track how it's affecting physical activity, how it's affecting your coordination with typing, writing, whatever your day-to-day chores are. If it's with ironing or vacuuming, if there's some degree of physical exertion that's going on a lot more sooner than you would expect, have this written down and bring it to your doctor. So, because it's really hard to determine if you're really having an off period or symptoms where your meds aren't kicking in, or is it about some other exertional issues that's going on? So
And
you want
Dr. Thakkar, if I recall, I believe Thriving with PD, the website, as if everybody can see that you can see Thrive in all of the corners, that they actually have a Parkinson's symptom tracker. So I'm going to put the link in the chat just in case anybody, but that's a great, print it out and use it, and as a way to, if you're wondering, well, where am I going to write this down, or what's the most useful?
Yeah, great. Thanks for pointing that out, because having those resources and then kind of gives you a clue and a position of where do I start. So yeah, please look at that website. And so when we are having difficulty and we feel like maybe we're not as good during the day, is that an off period? And so that's the term is when the medicines aren't fully kicking in or have worn off. And again, when you take a medicine, really it takes time to kick in and then it wears off. And as it's wearing off, you can feel like symptoms of the medicine are reduced, where you're slower, maybe tremulous, maybe there's a mental fatigue. sometimes there's a dose failure. And what a lot of people don't realize is with levodopa, it's actually build up, it's actually amino acids. So when you take it in, it absorbs in the intestine where you absorb other proteins. So when you take this medicine, carbidopa, levodopa, whether it's the Cinemet generic form, or if it's a branded form, Rytary or Crexont, or even if you're getting certain types of continuous dopamine through like Duopa, we do see that there's dose failure because protein will block that absorption at that area. Because if you're having like a protein bar, or protein shake, or even eggs and fish and meat, it will block that absorption if you took the medicine right after or with it. So we typically ask a lot of our patients if it's tolerated without protein food or on an empty stomach, if there is such dose failure. But even taking the medicine, there's a delay of it sitting in the stomach, and if we're backed up and constipated, we just may not get it to absorb the way we want. So that's sometimes a partial on. So you kind of feel like you're getting there, but you didn't really feel like you're able to control all of your stiffness and slowness. Maybe we're walking but can't go as far. Maybe there's this kind of mental fog that's there, but you're like, I can get the words out, but I'm just not able to, in a large group, speak loud enough. So that may be a partial on. A lot of people wake up and they've got great rest and they feel just fantastic. And there's other times where you wake up, you don't feel good. You just don't feel like you're in a good state. And you take your pill and it takes time to kick in, and that's your early morning off periods. Unpredictable offs. This typically happens as the disease is progressing 5+ years into disease, 6, 7, 8 years, where again, your meds were taken and it just all of a sudden you took it 30 minutes, we're working well, and then now it stopped kind of having the effect that you would expect. So there's a lot of variability. And when we think about off time, what do you feel? Well, obviously the tremors, stiffness, and slowness that one was experiencing before come back. I've also seen people feel this off period when they're getting an infection, a cold, a flu. So they may see off symptoms more throughout the day, even if they're taking their pills. So again, stress on the system makes that a more likely to be more frequent. We also see that, again, hard to get the words out, softer speech. You may have some imbalance. Again, think about how you're getting out of a chair, turning in bed, twisting, how you're playing golf or tennis or pickleball. Like, again, are you having some issues getting out of the car when you're getting to the grocery store, whatever it may be. These may be certain situations of off time. Like many people can experience, dopamine affects mood. So again, we may feel a little bit of anxiety. I've had some patients feel like palpitations, or they kind of get hot and sweaty. So again, those type of situations could be part of the off phenomenon. And pain, again, typically more with the dystonic patients, those who have more rigidity, you see a little bit more pain in those situations, or cramping. So the data suggests that when we look at patients who have off, 90% of people have some experience of off time as the disease progresses. 65%, at least within the first 2 hours of the day, can have such an off. And then there are people that are experiencing more than 4 hours of off periods in a day. So our goal should be, can we minimize these symptoms? Can we get moments where we're again able to get through our workday? Maybe it's time at a sporting event for our grandchildren. Maybe it's through a movie. We start seeing that, again, off time can interfere with what we want. So, if we have the signs and you're aware of it, then it can really have a proper discussion with the neurologist to determine where we want to go next. More than half of the time where patients come into a clinic, they don't discuss the off symptoms because they're not aware of it. And so I'm hoping that already what we've talked about, you feel more empowered to know what symptoms you could be looking for to address it. Now, other key thing is be very particular about timing of medicines. If you're erratic on your medicine timing, you will not be able to know what an off time is or an on time is, because there's no way of basing when you took the pill. And if you're not consistent, then you really don't know how long it took for the dose to kick in or how long it is for your next dose. And so we really want you to be disciplined in that, really talk with the doctor about timing. One thing I always hear is like, oh, my doctor said 3 times a day. So that people take it every 8 hours. Or they say, well, I was told to take it, 3 times a day, so take it with meals. And then you may not get an on time because you took it with food and it may be blocked. So really it's timing, and work with your doctor to say, what's the best timing for me And again, if you get side effects of nausea or upset stomach from the medicine, then you want to take it with maybe bread, crackers, maybe carb-based foods. And then if you are having some protein-rich foods, maybe wait at least 45 to an hour, so that there's no limitations by it. So you don't want to just accept that you're okay or doing fine. Really want to address, how do I be the best version of me, and how can I feel like I'm 20 years young, right? Like, you just want to have that tenacity. So levodopa works as a therapy. Levodopa is like levothyroxine. Many of you may also know what thyroid pills are, right? Thyroid pills are as a natural hormone to help our body supplement this energy. Well, just like levothyroxine, you have to take that on an empty stomach. Levodopa also needs to be absorbed properly and should be away from certain foods, even irons. But once it gets into the system, we know that it turns into a gold standard of dopamine because it comes into a natural form of it. So it's really not a drug. It's more of a strong, potent amino acid base that your body breaks down and turns into dopamine in the brain. And it allows for those nerve terminals to get the signals that we need. And then that way you can feel like you're getting the adequate control. So once it kicks in and then it wears off, right? Like, we're expecting to kick in and it wears off. There are these cycles. And so some of our medicines of levodopa do not last long, and it does wear off. And where you are in the disease state, how early you've been diagnosed, how late you've been diagnosed, it will vary from dose to dose. And as the disease progresses, it takes time. And you can see in that blue area, the gray area, that it takes time for the medicine to kick in to get there. And then we're in it for a certain amount of time, and then we shoot over that appropriate levels. And that could be when we're getting maybe dyskinesia. And then as it's dropping down, we can feel not as good, but we're still physically looking fine, but we don't feel as energetic. And that's when it's getting into our off state. So we want to really keep into that gray-blue box without overshooting and being undertreated. So as we see, as the disease progresses, we call this motor fluctuations. The medicine kicks in, hits a peak and drops off, hits a peak and drops off. And our goal should be, can we just keep into that smooth level and keep that level just right? And that's when we feel that we're in a sustained on time. We don't want to be just taking pills constantly every hour or two, and then now we're having way too much buildup and we're above the levels of good on time, and now we're just feeling like a wiggly. Had a patient who felt very anxious because he was taking too much pills. He was constantly twisting and turning, but it didn't look so obvious to him. People aren't aware of their dyskinesias, but he was getting what's called diaphragmatic dyskinesia, which is the diaphragm. And his respiratory situation was, he felt like he couldn't breathe well. So he kept thinking, I'm not breathing well. I'm undertreated. So he kept taking more pills. And it was actually that he needed way less pills. So again, really talk to your doctor about all of your symptoms. We don't want to miss something. And then you don't want to assume that you're managing the Parkinson's based on pure symptoms. You need to talk with your doctor so we can find out what's really related to the effect of the medicine. So there are different ways of optimizing our on time. We have, again, ways of sustaining an increase in the amount of medication as well as the frequency. We have boosters called MAOB because they're little enzymes that go and eat away at our dopamine. And if we block them, then we can sustain dopamine still in our system. COMT inhibitors, if we add that, again, sustains the longevity. These are another enzymes that break down dopamine in our brain. And if we add on a dopamine agonist, these are medicines that work postsynaptically. They don't work where when we're low on the dopamine. It works on the back end where it helps stabilize signals, the electrical component of it. And that's, again, other therapies that are different from levodopa. We can add rescue medicines. These are the ones that we have that maybe can inhale, or you can have as an injectable. And we used to have one that used to dissolve under the tongue, but no longer in the US. There are other types of non-levodopa medications that also help in other areas of the brain and can control also dyskinesias. And there also are now, unfortunately, just recently, you may have seen in the news that we have longer lasting carbidopa levodopa formulation. So it's been extremely exciting and well received from our patients who've been on it. I was told I'm an early adopter of the therapy, and we've been seeing a lot of amazing outcomes where patients have felt that they're not as dependent on taking a pill 4 times a day, 5 times a day, 6 times a day. Now they're doing it 2 or 3 times a day. So really unique to have better versions than the immediate release that was created over 50 years ago. We have the controlled release that came out, in the late 90s, and then now we have the extended release formulations. So amazing outcomes for patients, that we have technology that allows for the medicines to absorb where they need to. So we want to set the goal of treatment where you got the right medications to make your life go. You don't want to work harder, you want to work smarter. So consult with your doctor, make sure that you guys have a good regimen. Uh, you know, have loved ones come, have your care partner, whoever that is, because we also get a lot of information as clinicians, what is going on when we hear other people's perspectives. I have so many times that patients come into the clinic and the spouse is like sitting like this and they say, I can't speak, I'm not allowed to speak. And we're like, no, 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 I need to hear what's going on. And, it's really informative to hear because, there's a truth and there's a truth. And so you want to hear both perspectives. We're really not good at judging ourselves and remembering things. So again, write these things down. So the disease does progress, unfortunately. There are changes that we need to make as clinicians. And a lot of my patients I see every 3 to 4 months, and we want to really keep track of what's going on. So again, having that good communication is good. Always have your med list, have it updated with the right doses from other doctors. Make sure you have a consolidated therapy of all your medicines and supplements so we know what's going on. Don't be afraid to advocate. I think it's a true part of being your own health protector, I guess. I think that you can only advocate for yourself so much, and that's why also having your caregivers be another voice. Sometimes us as clinicians, we get kind of limited in our thought processing, and we go with the okay, it's fine, everything's fine, and the patient feels fine. But what else is really going on? Like, what can we achieve? And so today, like, it's been one of my days that I've been on it when I'm telling patients, like, how can I make your day better? What can we do to make things better? And I think that's an important thing, that there's always room for improvement with all of us, even if you don't have Parkinson's. So the changes that we need to make, again, is really be mindful of a healthy diet. That means low sugar, glycemic spike fruits, a lot of veggies that are appropriate for your body, because you don't want to be taking certain types of, like, say, asparagus too much and now you have a gout issue, right? Know which vegetables are good for you. Make sure it's appropriate for your digestion. Have appropriate whole grains, less processed foods, a lot of lean protein. So if you're looking at this and you're saying, well, where do I get this information? Online support, look at Mediterranean diet. Don't go into any like fad diets. If you have access to a nutritionist, highly recommend doing that. Online support for healthy diet and antioxidant-based diet, again, is really important. By no means has there ever been any true data that says alcohol is good for the brain. So again, cut those down. Alcohol is not good for the brain. It affects your balance. So if it affects your balance just by drinking a little bit, it's going to make your Parkinson's symptoms very imbalanced. So we really know that people have a problem with sleep because if they have alcohol or sweets and desserts late at night, it really affects the sleep cycle. So you got to get your adequate rest. Don't push yourself too late. With this hour change, it's gotten darker. Don't push yourself too late. Get to bed a little bit earlier, and don't take sleeping meds too late either, because they'll linger in the morning. So maintain a good discipline of exercise. If you have a good discipline, it will sustain your energy, and you may be feeling weak or tired, or that may be unrelated to actually just the Parkinson's. And again, if you are strengthening your core, if you're strengthening your endurance, you will feel stronger, and it's not because you need more medicines. So yes, it's not all about dopamine, as it's meant there. There is a lot of dopamine out there, and it doesn't have to be in a pill form. The concept comes where you can live with Parkinson's as if it's not a disease, and you have a strong sense of control. And again, the quality of life is what you aim to sustain as best as possible. So be curious, read, talk with others, set your goals, set realistic goals too. And what we've learned is you definitely aren't alone. You have a whole team around you. You have support. And if you don't feel like you have the support, go out there and get it. See if talk to your doctor. Is there a social worker? Is there counseling? Is there a psychologist I can talk to? And so hopefully today you've learned about what off time is and how different it is and how dramatic it could be, and what's important to talk with your doctor. many patients with PD have to adjust their medicines, but you can adjust it by yourself, have a game plan with the physician as to why that needs to be adjusted. And like I said, we've had newer therapies that exist, and we don't have to live with the medications that were existing at the time of Nixon. We have these newer maximized versions of levodopa that may not create the complications that we get with our older versions. So questions, comments, hopefully no
Yes.
concerns.
Thank you. Yeah, we had quite a few questions and comments come through. Actually, one of them reminds me a little bit of the conversation you and I were having right before we before we started this live stream. And so someone says, I tell my neurologist I'm wearing off, have extreme fatigue, and she refers me back to my primary care doctor, then says I'm doing fine and see her again in 6 months. Advice. And we talked about sometimes, especially, just the difference in the types of doctors, neurologists you may go to. And
Mhm.
um, so how would you advise that person in terms of advocating for themselves?
For fatigue and things like that, I would say, you know, I would be, because fatigue is such a difficult term, like to grasp for even clinicians. It's one of those things like, when are you fatigued? I think we need to be more specific. Is it time of day? Is it after a certain activity? Is it cognitive fatigue? Is this a physical fatigue? um we need to be more directive about it, and then that way the doctor can look into it, number one, and the neurologist needs to understand that, look, I've worked up my labs. I've got my complete metabolic panel. My B12 and vitamin D levels are normal. So you're going to say, well, like, how do I know I need to get that test? Well, these are things, again, why we have this discussion. You've got to make sure that all your blood work is normal. Make sure your thyroid is fine. Um, there are people who have congestive heart failure issues and heart issues. And I've had many people complain of fatigue that actually had irregular heartbeats. And then once they got a pacemaker, all of a sudden, like, they're vibrant, they're full of energy, and there's no more of this fatigue. So, also get your EKG, make sure you get your general workup done. Leave no stone unturned, but we want to really get an adequate addressing these labs. And again, you don't necessarily need more brain imaging, because brain imaging doesn't necessarily tell you anything. It's really about your blood work for fatigue. Maybe it's your diet. Again, another thing is, could be time of day and when you're eating and the fatigue. So I've seen people, when they've changed their diet and they take smaller meals but more frequently throughout the day, a lot more sustained energy, less fatigue.
And I think the other thing too is what you're thinking about and what you're talking about, you're a movement disorder specialist. And we do really encourage folks that if you're not seeing a movement disorder specialist, if you have the ability to, whether there's one nearby or I know there are some out there that are will do things remotely. Uh, it's just a different conversation. You see movement, you see Parkinson's, Dr. Thakkar, all the time. So some of those questions are easier for you, I'm guessing, to be thinking about. If someone's like, "Well, I'm really tired," or "I'm fatigued," if they use those words, you're going to ask clarifying questions.
Yeah, and again, it's not that the general neurologists aren't well trained in Parkinson's, but again, a movement disorder specialist is focusing only on Parkinson's, so we have the time and the ability to have that thoroughness. I think, again, that's why if you are seeing a general neurologist that's interested in Parkinson's, because if you read up on general neurologists and you're seeing someone, they'll say that they're specializing in epilepsy, neurology for Parkinson's, for neuropathy of from diabetes, or if it could be stroke related. So they're talking about what they know. Um, but that doesn't mean that they only specialize, and that's what movement disorder specialists are, that we're focusing only on Parkinson's. So that mindset should be that, maybe you want to see a movement specialist once a year, once every 6 months, in conjunction with your neurologist, so that you can kind of question about what else I need to do, what else is needed. And seeing a movement disorder specialist does not mean that you have to go for brain surgery and that you're only scheduled to go there because you need that higher level of care. Higher level of care could be being aware of the newer therapies that exist, the therapies that have existed for the last 10 years, also that have been new relatively, and allow for sustaining the benefit of on time without necessarily needing just more and more levodopa. There is so many ways to manage Parkinson's now. Um, the list of medications that were like the MAOB inhibitors, those COMT inhibitors. I mean, we have such newer therapies that, we got some from Japan that they've used for, 18 years. I mean, it's just amazing what we have. But again, just in the last, 4 or 5 weeks, we've had a longer lasting levodopa. It's made a big difference in already our patients that I've been seeing.
Yeah, and one of the things, one of the questions that came through privately was about reducing levodopa as much as possible. You know, they take a lot of pills, and just quality of life is also really important. And when you're taking a ton of pills all the time, that can be a challenge. So, what do you feel is the maximum dose for levodopa? Can you talk about progression of disease? And increasing meds and adding on, especially for those who might be, early on in the disease or even, later on in the disease.
Yeah, so again, we do have to individualize our own amount of therapy. There are some patients who can't even tolerate a full pill, and there's actually versions of levodopa that are in quarters that you can actually break off. And some people have patients who need only a quarter of a tablet, and some people need as high as like 3 tablets every single time they take their dose. So, I've had some people who take medicines 8 to 10 times a day, and they feel like they're chasing these symptoms that they're going off. And it may be that they're chasing the symptom of feeling anxious or nervous. And it's again, maybe they just need a serotonin therapy and they don't need more dopamine. And so we end up seeing that, as far as a dosage number, you don't really need too much medication per dose. Maybe it's an absorption issue. Maybe it's, again, competing with certain intake of other foods. Um, I have some other patients who had like surgery in their intestines, and that really caused some scarring. And then now they're not absorbing because it wasn't allowing them to absorb in the first place. So again, really talk with your doctor, because if you're taking too much medicine where you feel like it's not kicking and you're taking more than 2 tablets per dose, and you're not really getting a good on time, and now you've got multiple boosters, or you've gone to 3 tablets per dose, and you're not feeling like it's sustaining long enough, that sounds like it's just too much. I rarely have people that are more than 2 tablets per dose of immediate release. We may use a combination of like an extended release version or an inhibitor, MAOB or COMT, and that may sustain the benefit. But if you're taking a pill every 2.5 hours, it's way too close. Seems too frantic for your day, because you're going to have some absorption issues with some part of your day when you're eating. And again, when you're getting to closer to 3 hours that you feel like you need your meds, that also may be that there's room for improvement.
And somebody had actually mentioned that the levodopa, because you had mentioned, I'm going to totally butcher this, the levothyroxine, is that how you say it?
Hmm.
That the half-life for levodopa is like 90 minutes, but levothyroxine is 7 to 9 days. Can you explain why, like as we progress, why we need more carbidopa, levodopa over time?
Yeah. And so that's a great question. We need levodopa. So the levo part of it means it's left-handed. So every chemical, any medicine is either right-handed or left-handed, but levo is what the body can take in. So that's why the levothyroxine is based that way, and the levodopa is based that way. So there's no retrodopamine, it's levodopa, and that is, again, a half-life is short because it gets broken down very quickly by a lot of enzymes. And as the disease progresses, we have absorption issues. The gut itself slows down. We're not having maybe as much uptake at these receptor areas, the scarring. Some people get diverticulitis, some people have other Crohn's disease. And so you see inherent issues as we get older. Number two is that in the brain, the pathways of dopamine are also being degenerated. So the more you take, you can't push so much medicine in because the pathway itself is blocked, or degenerated. So it's not necessarily that you need more, but you may just need it more frequently at lower amounts. So again, that's why we have these extenders and ways of sustaining the therapy.
And somebody asked about the stages of Parkinson's. Will I get worse after 5 years, 10 years, 15 years? We do know, obviously, that, and everybody says this, that one person with Parkinson's is one person with Parkinson's. You've seen one person, you've only seen one person. But generally speaking, what can people expect for the different stages?
Yeah, I'm going to add to that. When you see one person, you've only seen one version of that person, because the person is so different even in the stages, right? But Again, if you optimize your health, you're less likely to need assisted devices. The more you're exercising, the more taking your body, less likely your muscles are going to wither away. So you have to take action. You have to move around. The more you move around, the less likely that, you're going to have like cardiac issues and other, health issues that prevent you from working out and strengthening your body. So, the stages of Parkinson's, when they came out from the 5 stages, that was made over 30 years ago. It's a very antiquated um, perspective. We see that that's just the motor symptoms. And again, you could be in the first stage of Parkinson's for 10 years. You could be in the second stage for another 5 years. You can be in stage 3 for another 3 to 10 years. So it's not like it has to be that you're in it for a certain amount and this goes fast. It could be years. I had a patient who I saw 5 weeks ago. She's 40 years with Parkinson's. So again, it makes a big difference because if you get diagnosed early, you have a longer longevity of your life. So obviously you can live longer, but if you're getting diagnosed and you're 90, it's a different disease state, right? And you may have other health issues. So the most important thing is, trying to maintain your best overall health. The stages are the stages because there is a progression to the disease state. But it's not that people have to go through those stages. I mean, I've seen people in stage 3 and 4, and now they got, newer therapies, better absorption of medications, or they've now got the appropriate, adequate therapies, let's just say, whether it's surgical or not. And now they look like they're in stage 1 or don't even look like they have the disease. So it's really about managing your symptoms properly with the right therapeutic intake.
And I know that we often talk a lot about the motor symptoms of off time, and you
Mhm.
did talk about some of the non-motor symptoms. So we know that and you mentioned this often when you were presenting, is that the conversation with your doctor is really important. And you emphasized that and said, I need to know what's going on and I want to hear, from the care partner or the loved one. And I know that sometimes and I've asked this on other live streams as well to different doctors because, different physicians handle these things differently, but what would you suggest to someone who might be embarrassed or they're concerned that some of the symptoms that they might bring up could cause some friction in the car on the way home or later on? How would you suggest to somebody who might be a loved one or care partner, or if there's someone with the disease and they're embarrassed about a symptom they're experiencing, maybe they don't want to talk about it in front of their loved one. How would you
Yeah,
suggest going about that?
so I always feel like, again, I sometimes, like, when I sense that tension, I always bring up like, hey, you know, there's nothing. I blurt it out, like there's nothing that, this is our circle of trust. This is your privacy. No one else needs to hear about this. I need to know how I can help you. And if I don't know what's going on, then I can't help. So I need to get everyone's opinion and everyone's perspective. So I usually can sense that. It's kind of easy when there's tension because there's either poor eye contact between the spouses, or the spouses rolling their eyes, or, shaking their head and whatnot. So one thing is that have that conversation well before, have a discussion, and it needs to be healthy, that look, these things could be something that needs to be brought up and it could help us, figure out what we need to do. Have the discussion as maybe we're under medicated, maybe we're over medicated, but we need to bring up this situation because it's a problem. If it's something to do with thinking and processing, then maybe it's a sensitive topic, but then still bring up like, yeah, maybe, we're noticing that we're a little bit forgetful, like maybe bring in the question in a softer way that doesn't have to be straight up related to the problem, and maybe hedging around it. It could be something as simple as, yeah, like we got, like, we're seeing some tension at home, and maybe it's about thinking, and they're like, yeah, he keeps talking about a cat, and I'm like, I don't think I remember seeing the cat around the house, and then just leaving it at that so that it's enough of a pickup for the clinician to say something else is going on, whether it's a possible hallucination or delusion.
Hmm. And actually, somebody did mention that they have Parkinson's dementia. Do you have any advice for someone living with Parkinson's dementia? Does their stages, prognosis, all of that look different in your, from what you've experienced?
It can look different, and I think that, again, the PD related dementia could be also exacerbated or irritated by other medicines that one's taking. Again, I've seen it with someone who has sleep apnea and they're not monitoring their sleep. They haven't even been corrected or fitted for their CPAP machine. I've seen that be, again, that if there's any stress on the system. I always had this one patient who he says, the wife says, always a little more confused at night, and that PD dementia went away when he stopped drinking alcohol. And it was just one glass of whiskey a night, that once he stopped it, he wasn't as confused and wasn't seeing things in his sleep. And once he woke up. So again, there's a lot of different situations that arise that create like that dementia associated with Parkinson's. Now, it's very different from the Alzheimer's perspective, but again, patients with Parkinson's, when they have dementia, they can have, a very similar issue like someone with Alzheimer's. And so it's not that you can't have Parkinson's and have Alzheimer's at the same time. You can have both symptoms. When we actually do lumbar punctures and we look at the abnormal proteins for what's in the CSF or the cerebrospinal fluid, you can see both the same abnormal proteins for Alzheimer's in patients with Parkinson's. So it's not we call it mutually exclusive. And it is important to address those cognitive issues. PD dementia means maybe you're misinterpreting things, seeing things that aren't there, or misinterpreting how it looks. And I've seen people fall at a higher rate because the ground looks a little like sketchy or a little uneven.
Yeah, and it's it's interesting. You talked a lot about having people write down their symptoms, bring that in, because you're right. You're not going to remember. I mean, I don't remember what I ate for lunch yesterday. I mean, I think that's a cliche everybody says, right? And
Mhm.
so I think the other thing that's really important, and we had I guess it was several weeks ago now, maybe it was maybe it was a month or two ago. See, I can't even remember. But we had on a pharmacist who, to talk about access. And that's one of the things that comes up often is about what medications are you on? And I think even in this, knowing those things, your doctor, knowing what you've tried in the past, chances are, whether they're coming to see you for the first time or going to see their neurologist, having a list of what are the medications you're on, because to your point, it's what are your symptoms and what else are you on? Because some of these things could be causing some of the symptoms you're experiencing. So it might not be an off time. But when you want it, the more information you have, the easier it is for you to test things out.
Correct.
So to that end, we actually have a question about let me see what they said. They say, I have had a constantly running nose and it doesn't seem to be allergies since it doesn't respond to medication. Is this a symptom of PD or could it be related to loss of smell?
It's probably associated with PD, and we have a lot of runny nose and postnasal drip, and we can feel like phlegm or saliva is kind of sneaking back here. So a lot of patients get runny nose after they're eating something. It could be certain sugars from the foods, certain dairies. We see that also aggravates kind of this runny nose. But the glands, the salivary glands, which is around the parotid and underneath the submandibular, they're a little bit hyper in Parkinson's. And we actually can use, if we get like a little biopsy of the gland, you can actually diagnose Parkinson's that way, 60% of the time. But regardless, there's some abnormal proteins here that create excessive secretions, and that secretions go, again, the gland can go to the nose and cause this runny nose. The nose doesn't start here, it starts actually right here. So the gland's actually from the mouth and around. So we do see that from Parkinson's. There's some really amazing options that we can use to treat. And I think also maybe seeing an ENT specialist just in case, to make sure there's nothing else going on, because we do sometimes see a lot of other sinus issues that may be going on that's needs a specialty care.
And we're almost at time, so I'm going to ask at least one more question. And Hope had asked, are natural supplements good to help with tremors?
Natural. So again, you got to be careful with what natural means. I actually had someone literally yesterday who's taking a lot of Mucuna purines and too much, to the point where he's having a little bit of involuntary movements and maybe some visual disturbances. So something that's natural doesn't mean it's good for you. If you wanted to go and talk about natural things, talk with your primary care doctor for make sure like which vitamins you're on and what's appropriate and what's necessary, but also get those lab works and bring it to your movement disorder specialist and then say, look, this is the list of my supplements, because I do see sometimes supplements block the effect of our prescription medicine. So I have some patients that take iron and they take it with their levodopa, and that sometimes blocks the effectiveness too. So whatever is natural, I would say there's not really too many things that are out there that are natural to reduce tremor. Maybe it helps with one's anxiety. Some people do like CBD, but avoid the THC because that really can cause some other abnormal problems. So you may want to talk with your neurologist and primary care as to what is the appropriate natural therapies that works in conjunction with your general health.
Well, thank you. And we are at the top of the hour. Wanted to thank you again, Dr. Thakkar. It's always an absolute pleasure to have you on our programs and sharing your wealth of knowledge with our community. We will have this posted. It is recorded, so it will be online if you want to take a look at it again. And for those of you who joined us afterwards in the future, if you have, if this raises any questions for you, feel free to shoot us an email and maybe we'll have a topic on that as well. So thank you, Dr. Thakkar. Thank you to our friends over at Amneal for making this possible and bringing us all this wonderful information. And have a wonderful Thursday and a wonderful weekend, everyone.
Take care. Thank you
Bye-bye.
for having me.